Nice. All right, everybody. Thank you for joining us. This afternoon, we're going to be talking about arrhythmias. Arrhythmias are super fun, and it's important to know better than other topics. One, because they're great, and then two, there aren't a ton of things in medicine where time is of the essence, but this is one of those. It's more helpful to know your arrhythmias like the back of your hand than maybe some of your endocrine pathways. You always have a chance to look those up, but realistically, when someone is in an arrhythmia, it is helpful to know what to do in that moment. Like Dr. Simpson said, we do a lot of training on how to talk to patients and how to be empathetic, but realistically, it's good to know some facts at some point. Asking a patient, how do your palpitations make you feel, only goes so far. It is much more useful at some point to your patient and your nurses if you know how to treat them. So that's what we're going to be focusing on today, how to identify and treat them. So all arrhythmias can be, we'll start with tachyarrhythmias. All tachyarrhythmias can be broken down basically into two questions, and they're super useful in creating your differential and identifying what's going on. So is the QRS complex narrow or wide? And then whether the rhythm is regular or irregular. If you are able to successfully identify these two components on any EKG that you look at, you'll be able to successfully identify what tachyarrhythmia you are facing. So we'll start with narrow and regular, and a word on the term supraventricular tachycardia. So SVT, supraventricular tachycardia, technically encompasses everything that is not a ventricular tachycardia. AFib, AVNRT, AVRT, A-flutter, ATAC, sinus tach. These are all supraventricular tachycardias. However, in the common parlance of cardiology, we don't include all of these when we say SVT. If an attending asks you to name the SVTs and you name all these, you'll be technically right, but they'll still be annoyed at you. Commonly, we separate narrow and regular rhythms into sinus tach, atrial flutter, and then if you say SVT, this is a totally legitimate way to cop out and say it could be AVRT, it could be AVNRT, or it could be atrial tach. We just can't tell from the EKG without a little more information. So if you say SVT meaning one of those three things, that will be fine. If you say SVT meaning any of these things, that will get you less credit. So sinus tach is can be thought of as the scariest arrhythmia. And the reason why is because if a patient has sinus tachycardia and you don't know why they have sinus tachycardia, you are missing something. For the most part, it's very easy to identify in the septic patient or the patient who's actively exsanguinating in front of you, why they're in sinus tach. On the other hand, if they're just sitting there and you really think that they're in sinus tach, that's a major issue because for the most part, something is driving that and you are missing it. The important thing to know about differentiating between sinus tach and other arrhythmias that is super useful is really, do they have a reason to be in sinus tach? If a patient comes into clinic and their heart rate is 130 and they're just sitting there, it is way more likely that that heart rate of 130 is an arrhythmia. If on the other hand, they're coming in with a gunshot wound and their heart rate is 130, they have a lot of reasons to be sinus tachycardic. You wouldn't say, oh gosh, I think this might be a flutter with a little bit of conduction block. Let's cardiovert them. You're like, that's probably sinus. So if they have a reason to be tachycardic, sinus is going to be more likely. If they don't have a reason and they're just sitting there and they're weirdly tachycardic, think about an arrhythmia. Obviously, some arrhythmias like AFib with RVR can make you short of breath and feel bad. That would give you the impression that you would be in sinus tach, but it's a good general principle to keep in mind. Remember that your max heart rate is 220 minus your age. So for young people, your max heart rate can get up to 200, but for our elderly population in their 80s and their 85s, their max heart rate is going to be 140, 135, even lower as you start to get into your 90s. Those patients should not be tachycardic to the 130s, no matter how much they're exerting themselves. So keep that in mind that as you get older, higher heart rates are going to be less tolerated because it's the same as a 20-year-old having a heart rate of 200, but also they really shouldn't be able to generate a sinus tachycardia to those high rates. That would, in an older person, a heart rate of, again, 120, that's almost their maximum heart rate. That's going to be more likely to be a arrhythmia. There is a inappropriate sinus tachycardia syndrome that can happen. It's a little more detailed, a little more of a diagnosis of exclusion. For the most part, it's not going to be your answer. Much like anxiety is not the answer for shortness of breath, except when it is. Inappropriate sinus tach is not your reason for sinus tach, except in the few instances that it is. So we'll start with atrial flutter for our first narrow regular arrhythmia. So what's happening in aflutter is that you have a circular pathway in your right atrium that goes at about 300 beats per minute. It's very reliable, the anatomy of the right atrium and the way that it produces this circuit. It can either go clockwise or counterclockwise. The typical flutter goes counterclockwise, atypical flutter goes clockwise, but they both go at about 300 beats per minute. So what that means is your atrium's going 300 beats per minute and your ventricular rate is going to be determined by your AV conduction ratio. Most AV nodes will conduct at a rate of 2 to 1. So for every 2 atrial beats, you're going to have 1 ventricular beat. But it can be variable. So you can get 3 to 1 or 4 to 1 block in atrial flutter. So that results in most of the time an aflutter rate of 2 to 1 conduction is going to be 150. It's half of that 300 atrial beats per minute coming through in your ventricles. So when you see a arrhythmia with a heart rate of 150, given how common that is, you should really be thinking about atrial flutter. In situations where the AV node is hyperconducting, you can get 1-to-1 conduction in aflutter, which is really dangerous because with 1-to-1 conduction in aflutter, your ventricle is going to go at 300 beats per minute. That's going to result in a really hemodynamically unstable patient who can rapidly degenerate into VFib. So here's a nice EKG showing typical atrial flutter, and some key points to remember when you're looking at the EKG here is you want to see inverted flutter waves in 2, 3, and AVF because your circuit in the atrium is going like this. It's going to produce inverted flutter waves. So it's going to be, if you can see here, they're going down, 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 down. 2, 3, and AVF. If you see inverted flutter waves, that's going to be very classic for typical atrial flutter. This is 2 to 1 conduction. So you see flutter wave, ventricle wave, flutter, basically atrial flutter wave, and then your ventricular QRS complex. This is going at a rate of about 150. So this is a classic example of atrial flutter. So how do you manage aflutter? AV nodal blockers are going to be your mainstay for acute flutter. But compared to AFib, it's a lot less reliable. Your beta blockers, your calcium channel blockers are not going to work as well for flutter as they do for fib. So you may find yourself in those situations where, gosh, we've given them a lot of metoprolol, a lot of DILT, and we really can't control that rate. It's not uncommon. You're not doing anything wrong. Don't be afraid to crank up the beta blocker and then say, hey, this flutter is not responding to nodal blockade. We need to think about antiarrhythmic therapy. We need to think about a TEE cardioversion. Just know that it's worth trying because some people respond, but compared to fib, flutter does not respond as well to those AV nodal blockers. So if it doesn't respond, you can think about rhythm control, but ultimately long-term control of aflutter is going to be in the form of a catheter ablation. And flutter ablation is really, really awesome because like we saw on that last slide, we basically have a circular electrical circuit that is very reliable and it always goes in this pattern. So all you have to do when you do a flutter ablation is stick a catheter up in here and you do an ablation on the cavo-tricuspid isthmus line. It's not important to know what exactly that is unless you want to be an electrophysiologist. But what's important to know is that all you do to interrupt that circuit is you take the catheter and you burn a small line, you burn a small scar right in that area, and that totally interrupts your circuit. And aflutter ablations have a 98% success rate with only one ablation. So it's one of the most I think it is for both. That's a good question. Don't hold me to that. I'm sure there are some nuances where typical flutter might be harder, but for the most part, they are using the same circuitry. So I think the CTI ablation does work for both. It may be more difficult for one or the other. Yeah. So SVT, we talked about SVT. Can anyone tell me basically which, based on these diagrams, which one is AVRT and which one is AVNRT? Any budding cardiologists want to stake their claim here? AVNRT indeed, AVRT. Nice, Ben. So AVNRT is AV nodal reentrant tachycardia. The reentrant tachycardia is occurring solely within the AV node here. AVRT just leaves out the node part, and it's just atrioventricular reentrant tachycardia. That implies the existence of an accessory pathway through which you start to get this circular conduction. So AVNRT, again, is the one that occurs only in the node, and this is the most common cause of palpitations in patients with normal hearts. It's more common in women, and 75% of cases of AVNRT occur in women. It is commonly provoked with exertion, stimulants, alcohol. These are the arrhythmias that you see in otherwise young, healthy people who've done cocaine and their heart rate is going at 180, and you've just got to break that circuit. And how it happens is pretty interesting, and it's actually not too complicated. So bear with me here. So this is your AV node. You've got a slow pathway and a fast pathway within the AV node. Why it was created that way, I'm not sure. You can ask whatever deity you believe in. It doesn't seem to make a ton of sense. I'm sure there's a reason, but honestly, it seems like it just causes more problems than anything. The fast pathway has a long refractory period. The slow pathway has a short refractory period. So what happens is when you get a sinus beat, it goes down the fast pathway, it goes up the slow pathway, it meets the slowly conducting one about here, they cancel each other out, and the electrical activity gets down to the ventricle, no problem. But if you have a PAC, premature atrial contraction, basically an extra random atrial beat that can come with sympathetic stimulation, all of a sudden you've got a beat coming down while the fast pathway is refractory. Remember, that has the long refractory period. On the other hand, the slow pathway is ready for business again. It has the short refractory period. So you've got a premature atrial beat and electrical activity coming down the slow pathway. It goes down the slow pathway because it's available. It doesn't go down the fast pathway because it's not available. It comes down here, and then when it gets down here, all of a sudden the fast pathway, the refractory period is over. It's ready for more electrical activity. And all of a sudden it goes back up the fast pathway, and that's how you get your circuit. So it's going up and down, up and down, up and down at a rate that is a little variable compared to atrial flutter. It's stimulating your ventricle to beat all the time. It's also stimulating your atria to beat in a retrograde fashion. So here's a good example of AV-NRT just to show sort of what it looks like. I just want you to get a general sense that in general, AV-NRT is going to be a little bit faster than your maybe your typical flutter, which is going to be around 150. AV-NRT usually will be around 160, starting to get into the 180s in a young, healthy person, maybe who's on cocaine, you can get them up into the 200s. But think AV-NRT when you see an EKG like this. Can anyone tell me what these waves are in this AV-NRT? Just shout it out if you know. Retrograde P waves. So retrograde P waves occur as your electrical circuit sends electrical signals back to the atrium. Your atrium are contracting after basically this AV nodal activity and slightly after your QRS complex. So that's why you see a QRS complex, and then that electrical activity is getting sent back up the pathway. And this is actually a P wave, a retrograde P wave, signifying atrial contraction. So look out, if you see these, think AV-NRT. Management of AV-NRT. This is the time that you want to think about vagal maneuvers. AFib, aflutter don't really respond typically to vagal maneuvers. It's worth a shot, but typically they don't. So here's when you tell a patient to Valsalva. Here's when you would consider wetting an ice towel and placing it on their face. You do not need to throw a bucket of ice on a patient, however dramatic and awesome that may seem. For the most part, if it doesn't work, all you're left with is a soaking wet patient, a confused nurse, and then you are left to figure out what to do after that, after your super cool idea did not work. Before you throw a bucket of ice water on someone, adenosine is a good option. Adenosine transiently blocks the AV node completely, so it's especially useful if you have your reentrant circuit going through the AV node. That will interrupt it entirely. You do a 6 milligram IV push, a 6 milligram IV push, and then 12, unless you want to jump to 12 on the second one, that's also fine. Like flutter, AV NRT can be ablated pretty easily. What they do is they take their ablation catheters, they electrically find the slow pathway in there, they burn it out, and then all you've got left is a fast pathway, and it interrupts that circuit. It's a pretty successful procedure. Obviously, it's a little scary unless you know what you're doing, because you might accidentally take out the whole AV node and induce complete heart block. And that happens about 1% of the time. You know, 1 out of 100 doesn't seem like a lot until you've seen 100 patients, and then you're like, shoot, we gave one of them complete heart block. But for the most part, pretty successful. AVRT, on the other hand, is your AV reentrant tachycardia that doesn't involve the node, and that is because of the accessory pathway. The accessory pathway is an anatomic abnormality that for some reason is conducting electrical activity between your atria and your ventricles. Accessory pathways can come in a wide variety of forms, the most common one being WPW or Wolff-Parkinson-White, but there are other less well-known versions of accessory pathways like Lown-Ganong-Levine syndrome, and probably a bunch of others that someone discovered in one person one time and managed to publish, but those are your main ones. So WPW is the existence of that accessory pathway, and why WPW does what it does is really all due to that pathway. When you get electrical activity coming through this pathway, it starts to activate your right ventricle a little bit earlier than it would have if your electrical activity had just gone down your His-Purkinje system. That's why you get that delta wave. That's why your QRS widens just a little bit. Anytime that you're getting electrical activity that is causing your right and left ventricles not to beat simultaneously, aka from an accessory pathway, you're going to get a widened QRS. So in a patient with WPW in sinus rhythm, you will often see a delta wave. On the other hand, you can end up, that's in sinus rhythm. On the other hand, if you get a PAC again, where maybe you get a premature atrial contraction that gets sent down this pathway, and by the right circumstances, these things are no longer refractory and it gets sent back up through the node, you can get your reentrant circuit going through the accessory pathway and the AV node, giving you a EKG that looks like this. If anyone would be able to tell me basically on first glance the difference between this and AV NRT, you should skip residency and go right to an electrophysiology fellowship. The reason that people say, well, it's SVT, it's really hard to know whether this is AVRT or AV NRT. Truly, most general cardiology fellows will have a really hard time telling the difference. You might need an EP study. You might need, honestly, an expert opinion to try to weigh in on the differences. But we can tell by the narrow complex tachycardia at a very fast rate that doesn't seem to be flutter-like, and certainly is not sinus tach, that this is most likely an SVT, the kind of which matters in the long run, but in the short term doesn't matter so much. You have to interrupt the AV node again. So it's vagal maneuvers, it's adenosine. Long term, once they find out where it's coming from, instead of ablating your slow pathway within the node that's causing your problems, they just go in and wipe out the accessory pathway. So don't be afraid to say SVT. And I don't, it's impossible to tell AVNRT or AVRT without a ton of experience. But please familiarize yourself with what SVT looks like and how to manage it. It's very similar between AVRT and AVNRT. And it's really satisfying when you can get those rhythms to break. I believe Magda had a patient who went into maybe hemodynamically unstable SVT who broke with a giant bowel movement. I think the room was relatively covered in crap, but the rhythm was restored by some vagal maneuvers. So it's pretty great when you can get it to stop. What's up, Austin?
How does the ones that adenosine is contraindicated in WCW?
Great question.
You can invoke a one-to-one conduction of the ventricles.
You are absolutely right.
I saw it on there.
So AVRT with an accessory pathway, in the instance of a random premature atrial contraction and a circuit, you can block the node. On the other hand, what if instead of a circuitry pathway, your atrium is just going crazy? So what if it's an AFib generating AFib beats of 300 beats per minute? That can cause a lot of problems. So basically WPW in sinus, you get a little delta wave, which is fun to look at, but doesn't cause any problems. WPW with the reentrant circuit, also annoying, can be solved with a giant bowel movement. Not a huge issue for the most part, will respond well to cardioversion. But if you are in AFib or aflutter with an accessory pathway, that's when things get really dangerous. What's happening is your atria is beating 300 times a minute. Some of those are going down their His-Purkinje, going through the AV node. A lot of them are going to go through this accessory pathway. So you are going to get rapid ventricular conduction at a rate of like 250 to 300 that will look like this. That is when you've got to be sure that this is not basically AFib in the setting of WPW, because if you block that AV node, all of a sudden the only pathway that's left is this. So at least when you had the AV node, some of them were going down this pathway and you're getting some normal refractoriness. If you block the AV node in someone in AFib with WPW, it's all going to go down here, and this accessory pathway does not have the refractory period of that AV node, and you'll precipitate VFib. Your ventricle does not love going at a rate of 300 beats per minute, and it will fibrillate if it is left in that for too long. So it's really tricky, but worthwhile to familiarize yourselves with the EKGs that look like this. So this is almost 300 beats per minute. This is irregular, starting to get wide because things are going down the accessory pathway. Anything that isn't going down the His-Purkinje is going to get wide. This is going to be wide. It's going to be really fast. It's going to be really irregular. This is where you've got to say, hold on, before we give any beta blockers, we've got to look at old EKGs. Did they have a delta wave? Is there any history of WPW? Do you think WPW in that situation? Do you guys see, just on a quick glance, the difference between these two EKGs? So this is AVRT from a reentrant. It's narrow, it's regular, it's fast, it's like 200 ish. This responds to AV nodal blockade. This is irregular, it's wide. This is AFib with WPW. This will not respond well to AV nodal blockade. This is where you want to use procainamide. These patients are often going to be hemodynamically unstable. Most of the time, the emergency room is handling this, but it can happen on the floors in the ICU. So use procainamide if they are stable. If they are like this, they're probably hemodynamically unstable, and you should just go ahead and cardiovert them. Does that make sense? All right, and the last of our SVTs is atrial tachycardia. The only thing to know about ATAC is you need to see, basically what's happening is you're getting a focus of atrial activity that is coming from somewhere other than the sinus node. When electrical activity in the atrium is coming from the sinus node, you're going to get upright P waves in lead 2. If you see inverted P waves in lead 2, that is a quick and easy way to tell that atrial electrical activity is not coming from the sinus node. Atrial tachycardia is, to be honest, rarely super dangerous. It rarely gets as fast as any of the others. It's more noteworthy or notable in the sense that there's an ectopic focus that is driving their atrial rates. the management of that is a little more nuanced, and we can certainly talk about that at a later time. So now we've talked about all the narrow regular tachycardias. Now our narrow irregular tachycardias, AFib with RVR being the most common. This warrants a whole lecture in and of itself on how to manage AFib. But in general, we're going to start with beta blockers. We're going to use calcium channel blockers. You can use digoxin and you can use amiodarone. The way in which all of these help control the rate in AFib with RVR is that they're all AV nodal blockers. Even amiodarone, which is an antiarrhythmic, has AV nodal effects. So it really has sort of a nice 1-2 punch there. If your rate control strategy isn't working for RVR, or they have another reason to be in rhythm control, that's where you're going to use your antiarrhythmics. Again, sort of a conversation for a different day, just because it's a whole big topic on its own. And then multifocal atrial tachycardia is worth mentioning, pretty rare. I think this board's question buzzword is that it's common in lung disease, like COPD is associated with it. That's basically atrial tachycardia, but from a lot of different foci. So instead of one ectopic focus that is driving your rate, you're just going to have a couple of focuses that are driving your rate, as opposed to AFib, which is just like hundreds of microcircuits that are driving your rate. Okay, so we've talked about our narrow QRS complexes, both the irregular being sinus tach, SVT, and flutter, and our irregular being fib and multifocal atrial tachycardia, as well as flutter with variable conduction. So now it's time to talk about our wide QRS complex tachycardias. So never fun to be in the CCU and see this, but it'll happen, and you should know what to do about it. So wide and regular, there are only two options. It's SVT with aberrancy and VT. SVT with aberrancy means it's SVT with some sort of ventricular conduction problem, whether it's a bundle block or an accessory pathway. Something is making that QRS wide. For the most part, it's a bundle branch block, whether it's left or right. It doesn't really matter for the rhythm purposes of what's going on. But it's generally a bundle branch block that is making your atrial rate go through, basically your atrial activity go through your AV node, and then it widens as your bundle branch block prevents your left and your right ventricle from contracting together. Does anyone know how we tell the difference between VT and SVT with aberrancy? There's a particular set of criteria. It's the Brugada criteria, not to be confused with Brugada syndrome, which is a congenital syndrome that predisposes you to sudden cardiac death. But the Brugada criteria help us differentiate between ventricular tachycardia and SVT with aberrancy. These are pretty tough. It's important for today that you know them, and then as you prepare to go on to a cardiology service or the CCU, that you actually know what they are. So we'll go through them briefly, just to help you differentiate between what is likely a life-threatening ventricular arrhythmia and what is a supraventricular arrhythmia that could be solved with vagal maneuvers. So number one on the Brugada criteria is a northwest axis. That means that it is way more likely for your rhythm to be VT if the electrical activity is starting at the apex of your heart and going up in a circuit going towards your right shoulder. For the most part, our electrical activity starts in the sinus node. It goes down this way. It's going, for the most part, going to give you a negative deflection in AVR, which is your EKG, that point which senses electrical activity going this way. You've got a ventricular arrhythmia. Your electrical activity is going to, for the most part, be going up towards your right shoulder. There are a lot of exceptions, but if you're starting low and going high, it's going to give you a positive deflection in AVR. So you can see each beat starting here is going up, up, up there, up there. That is called a northwest axis because your axis of your rhythm is going towards your right shoulder. That is a very strong indicator that your rhythm is VT. On the other hand, if it was SVT with aberrancy, you're still having atrial activity that's sending things down towards the apex of your heart. You're really not going to get a northwest axis. The broader the QRS, the more likely it is to be VT. That's really just observed. Basically, a diseased myocardium that's going to be more likely to cause VT is going to be the one that has the widest QRS. The other things that are part of the Regradich criteria are things like AV dissociation, capture beats, and fusion beats. These are hard to see, but they really do help when you do see them. See a capture beat is something that's really nice to see in VT because it's pretty reliable. What's happening here is this is a ventricular arrhythmia, but while you're in VT, your atria is still firing. For the most part, the VT is going really fast. It's causing refractory periods throughout the ventricle, but every once in a while, a normal, narrow, complex ventricular beat that started in the atrium will poke its head through that VT, and that tells you, oh gosh, wow, okay, this is an atrial beat that has made it through the AV node, is going down the His-Purkinje in a narrow, complex fashion. Everything else is probably not coming from the sinus node or even in the atria at all. So this means that all this stuff is ventricular activity and of ventricular origin, while as this one beat was one lone normal sinus beat that's made its way through. So that's a useful way to tell that all these other beats are VT. Also seen in VT are basically these AV dissociations where you'll see random beats of atrial activity poking their way through the other ventricular activity. So we can show you, we'll come back to that in a little bit. And then lastly, positive or negative concordance. If V1 through V6 are all upright or all down, that's more likely to be VT. If they are alternating between up and down, that's more likely to be SVT. And then last point, this one is very specific. Again, for the most part, just want you to know that these exist and then revisit them at some point later in the year. If your RSR prime left rabbit ear is taller than your right, that means it's much more likely to be VT as well. So you've got a patient in the CCU, they've got a wide complex regular rhythm, they're really tachycardic. The likelihood of VT is much more likely if they're older, if they've got coronary disease, if they've got ischemic heart disease, a previous MI, or family history of sudden cardiac death. But on the other hand, the likelihood of SVT with aberrancy is much more likely if they've got a known bundle branch block, which looks like the same version of your VT that you're seeing now. So let's say a day ago, they were in sinus rhythm and they've got a left bundle. And now all of a sudden they're tachycardic and they've got a left bundle that looks exactly the same. It's going to be more likely that that's SVT with aberrancy rather than a new VT. On the other hand, you know, these aren't foolproof, but it's something that you can look at old EKGs for to try to help you tell the difference. So this EKG, I just wanted to point out, is SVT with aberrancy. It looks scary. It looks like it's VT, but it's actually SVT with aberrancy. And the reason that we can tell that is we're putting a lot of things together. It's wide, but it's not that wide. It's barely 120. It does not have a northwest axis. This axis in AVR is going down. That means the electrical activity of the heart is in general going this way. It does not have concordance within V1 through V6. It's going down here, but then it starts to go up here. So that speaks against VT as well. And we really don't see any AV dissociation. We don't see any random atrial beats. We don't see any narrow QRS complexes breaking through. So this would be a great example of a scary looking rhythm that all of a sudden isn't so scary because it's SVT with aberrancy. How do you manage this? So if a patient has a pulse, but they're hemodynamically unstable, you cardiovert them. If they're pulseless, you defibrillate them. There is a thing called slow VT, which you'll see in the CCU, which happens when a patient goes into VT, but they actually maintain a pulse and they actually are hemodynamically stable. Some people with VT, for the most part, go pretty fast. 150s, 200s, 250s. But people who've had a lot of ablations or have a lot of scars have some really crazy re-entrance circuits, and they can go into VT with a rate of 110. So it's pretty hard to tell sometimes that you have gone into VT, especially if their sinus rhythm was around 100. So often though, when this happens, they'll be at 100 and all of a sudden they'll go to 110 and you'll be like, what the heck just happened? Because it's a ventricular beat, it's going to be wide. That ventricle is just not contracting well. It's really circular. It does not contract as well as it would have if that electrical activity was going down your his Purkinje to give you a nice uniform conduction. So if you're in the CCU and you've got a patient who's at a heart rate of 100 and all of a sudden they go to 110 and it's wide and they've got a history of VT and maybe they're there for VT, it could be slow VT and they will most likely become a little hemodynamically unstable because that ventricle isn't contracting as well. And this just wanted to mention just because it's super interesting. When you're in the CCU, you'll get admissions for VT Storm, which is refractory VT. And there's all sorts of fun things you can do for recurrent refractory VT. You need to revascularize the coronaries if the ischemia is driving the VT. But while we're waiting on that, we use beta blockers to reduce the sympathetic tone, use amiodarone or lidocaine as an antiarrhythmic. Propofol is a great antiarrhythmic. Unfortunately, the thing about giving propofol is you have to intubate someone to give propofol. So if you're willing to do that, it will really calm down arrhythmias very well. Oftentimes people will be in incessant VT. We're shocking them, the lidocaine's not working. And you say, all right, well, you know, we're gonna have to intubate them because they're starting to get hemodynamically unstable, and we need to start thinking of other options. And all you do is you intubate them and you start the propofol and the VT goes away, which sucks because then you have to figure out what else can you do to get rid of the VT because no one wants to live the rest of their lives on propofol and intubated. A cool thing we can do with anesthesia's help is do a stellate ganglion block where you infuse continuous bupivacaine into the sympathetic chain on the side of the neck that can calm down VT. And then some of the cardiologists will say there's no antiarrhythmic like a balloon pump. When you offload the work of the myocardium by basically making it easier for your LV to contract, that will really reduce your VT as well. All these in general are temporizing measures in refractory VT. Ultimately, people can get VT ablations. One thing that any of you doing nights in the CCU will experience is the joy of having a patient admitted maybe a couple days prior for VT. They get them calmed down, maybe they revascularize them, and they've got them on lidocaine, they've got them on all this stuff, and they're super quiet. And they say, okay, we're gonna take them for an ablation tomorrow morning. And they say, okay, stop the lidocaine, stop the amio, stop it all at like 6 o'clock. And so all the lidocaine starts to wash out. And the reason they do that is they need to be able to see the VT when they're doing the ablation. So 8 o'clock rolls around, they're starting to get some PVCs. 10 o'clock starts to roll around, they're starting to get some non-sustained VT. And it is it's an excruciatingly long night as you watch the VT start to ramp back up so that there is a little bit of VT, but not too much VT when they come in to ablate them at 8 o'clock the next morning. It sucks. We've done it a lot. There's not a ton to do. Obviously, if the VT gets bad again, you can crank back up the lidocaine. But that is why that is happening. If you're saying, why are you doing this to me overnight? Why are you taking away my lidocaine? That is the rationale. It's not fun. I get why they do it. And who would want to be an intern ever again? All right, so that covers our wide regular tachyarrhythmias. I'm going to breeze through our wide and irregular arrhythmias. They are fairly straightforward. Wide and irregular arrhythmias can be polymorphic VT or torsades. These are very poorly hemodynamically tolerated. You will most likely be shocking someone if you see a rhythm like this. Maybe don't think about it too much. And then, like we said, with SVT with aberrancy, you can also get AFib with aberrancy. Again, that aberrancy, all it means is a wide QRS that comes from a wide bundle branch block, which in this situation would make your right ventricle contract before your left, giving you a wide QRS that would make it look like irregular VT. Again, AFib with RVR, we talked about the management there. All right, so we've got 15 minutes. Oh, go ahead.
For the AFib with RVR, like, is there a definition, and how do you decide they're officially compromised? I've seen patients that like their one team
So true. Great question. It's purely semantics. It's purely opinion. Technically, I think anything over 100 is tachycardic, so they're having a rapid ventricular response. People hang out in AFib at 110 all the time. So if you want a patient transferred to the MICU, you say they have RVR. And if you say they're stable on the floor, you say they're fine. It's just 110. There's not a definition. In general, goal heart rates in AFib are like 110 and lower. 120s are fine for the most part on the floor, bouncing around in the 130s. 140s, 150s, you should really think about what's going on and whether you need to increase the beta blocker or whatnot. But RVR is in the eye of the beholder. Okay, bradyarrhythmias. Just want to talk about a little more quickly. They are a lot fewer than our tachyarrhythmias. They're sinus bradycardia, AV blocks, and then our escape rhythms. So sinus bradycardia. There are non-pathologic and pathologic causes of being sinus brady. Being asleep will cause sinus bradycardia. Athletes, vagal stimulation, beta blockers, calcium channel blockers, amio, DIG, all of these things can cause sinus bradycardia, which are not an issue so long as you are asymptomatic. If you begin to become symptomatic on your beta blocker or calcium channel blocker, that is a reason to remove those offending agents, not necessarily put in a pacemaker right away. And then there are pathologic causes of sinus bradycardia: hypothyroidism, hypothermia, anorexia, hyperkalemia, opioid overdose. This sinus bradycardia will be better solved by treating each of these things individually, again, rather than attempting to pace someone. AV blocks, first, second, and third degree. Let's go through all of them. So first degree AV block is just abnormally slow conduction through your AV node. That is evidenced by having a long PR interval greater than 200 milliseconds. In in a patient who's asymptomatic with this, it makes you worry that they have some conduction disease, because they probably do, but it's not bad enough yet to do anything about unless they are symptomatic. It is really hard to prove that someone is symptomatic enough to get a pacemaker for first degree AV block. For the most part, first degree AV block results in EKGs that look like this with a perfectly normal rate. It's more of an incidental finding. I don't know if anyone, I can't think off the top of my head, having ever seen a pacemaker put in for first degree AV block that was symptomatic, just because it's so unlikely and so hard to prove. Second degree AV block is Mobitz type 1, and this is where you're going to see that progressive lengthening of your PR intervals followed by the blocked P wave. We can see here, you got your PR interval there. It's a little bit longer there, longer yet there, longer yet there, and then boom, that P wave is not conducted as your AV node recovers its refractoriness. Mobitz type 1 block is often asymptomatic, and it only needs a pacemaker if they are symptomatic from this. This you can get symptoms from theoretically, much more so than first degree AV block, but this you can definitely get symptoms from. So if you see this, if they are truly asymptomatic, it does not warrant a cardiology consult. If you think they have symptoms that could be related to this, totally warrants it. So it's pretty straightforward in terms of your assessment, and when you see this, it's are you having any symptoms from this at all? If they are, cardiology should evaluate them for a pacemaker. If they're not, they do not need to be consulted. Second degree heart block, Mobitz type 2, on the other hand, is where you start to drop your P waves at irregular intervals without that progressive lengthening. So you see normal conduction here, you see a P wave that does not conduct there, and then you see a return to your same PR interval there, but you're getting intermittently non-conducted P waves. That one is conducted, that one is not. So there's no pattern. There's no pattern here. You can have a pattern in that maybe every other one is conducted, like this one seems to be implying, but it doesn't have to have a pattern. The thing about Mobitz type 2 is it implies more serious conduction disease. Basically, in Mobitz type 2, 75% of the cases are going to be infrahisian. They're going to be diseases of this stuff. This stuff, when it fails, your the Purkinje fibers in your distal his is much more likely to progress to complete heart block. They're more sensitive and they are much more dangerous when they're not working properly. 25% of secondary heart block do occur at the bundle of His, which is right after your AV node. So that will still give you a narrow QRS complex right here. But as you start to get through here, for the most part, you'll start to widen out your QRS. This, the fact that it's infrahisian disease, it's distal disease in Mobitz type 2, predisposes you to complete heart block and is a reason to get a pacemaker regardless of symptoms, because of your risk of progression to complete heart block. High grade AV block is very similar here. It's just another version of Mobitz type 2, basically P waves that are not conducted, P wave conducted there, not conducted, not conducted. This would be a version of the pattern, a pattern you could see in Mobitz type 2, but it doesn't always have to be there for it to be Mobitz 2. Third degree heart block, no association whatsoever. This is where you get your calipers out, you march out those P waves, and you find a really regular rhythm that does not correspond in any sense with your QRS complexes. You see this P wave here, and you're like, oh yeah, that's probably conducted. It takes a little bit of extra thoroughness to realize, oh, why isn't there a P wave in the same spot by these other QRS complexes? Oh, this isn't conducted at all. It's purely coincidence that it looks like it would be. If you see P waves that are regular and not associated with a QRS complex, get those calipers out. If they march out and they're independent, it's complete heart block. Junctional escape rhythms. You're going to see junctional and ventricular escape rhythms in episodes of sinus arrest. Basically, if you have an MI that knocks out your sinus node and your sinus node ceases to function, your AV node and your ventricles have backup rates that are slower than your sinus node. The reason they're slower is so that they don't interfere with your sinus node when things are working well. And while my complaints with whatever deity you believe in are still present for your AV node, the idea of a junctional escape rhythm and the idea of a ventricular escape rhythm, I think, are very nicely designed. Here we see no P wave activity whatsoever, but we see relatively narrow beats that imply that this is a junctional rhythm. No P waves, narrow QRS means it's a junctional rhythm, usually occurs at between 40 and 60. Ventricular escape rhythms, if for some reason your horrible MI has knocked out both your sinus node and your AV node, or for whatever reason those two things have ceased to function, then you will get a backup rate of around 20 to 40, and this will have a typically wide QRS because this is arising from your Purkinje fibers. Your right and left ventricles are not going to be conducting very well together. So this implies that for some reason both your sinus and AV nodes have stopped functioning. How do you manage this? We talked a little bit about our complete heart blocks and our Mobitz type 1 and 2. Yeah, we talked about this. So this is type 1 heart block, does not need a pacemaker unless they're symptomatic, really hard to prove. Type 2, second degree, type 1 can get a pacemaker if they're symptomatic, which happens sometimes. Mobitz type 2, aka second degree heart block type 2, needs a pacemaker regardless of symptoms. And complete heart block needs a pacemaker regardless of symptoms. And obviously, if you have experienced sinus arrest and you're in a junctional or ventricular escape rhythm, you also need to be paced. So none of us can put in a permanent pacemaker to solve these issues for patients, but while they are actively dying in front of you because their heart is not generating enough electrical activity, what can you do to buy them some time until they can get a permanent pacemaker in the EP lab that afternoon or the next day? You can transcutaneously pace, and this was something that took me a while to sort of get the terminology down. Transcutaneously pace, meaning through the skin, is when you put the pads on somebody and you pace them on the Zoll defibrillator. You stabilize them in that method, and then if they aren't going to be able to get a pacemaker right away, you can call interventional cardiology or one of the CARDS fellows to put in a transvenous pacemaker, basically a wire going through the IJ down into the right ventricle that will pace the heart so that they don't have to be shocked with the pads every second. It's pretty nice to be able to do that for people. You would not want to transcutaneously pace someone for any significant period of time. Like, let's say this happens when you're on nights at 10 o'clock and you're like, oh crap, they just went into, they just had sinus arrest, or they just went into some sort of bradyarrhythmia where I needed to pace them, whether that's complete heart block, sinus arrest, whatever. Transcutaneously pace them to make their heart beat, but you would not leave them on that all night until the team comes in the morning to do a permanent pacemaker. You would get that temporary wire in overnight. Transcutaneous pacing hurts. Most of the time patients are dying if they need transcutaneous pacing, so they're pretty out of it anyways. If someone is still with it and they are being transcutaneously paced, whether or not to give them a mild sedative is kind of debated. For the most part, you would want to do it, I think, but not if it's going to make them hemodynamically unstable. So maybe a little Precedex, maybe some Ativan would be great. Anything stronger, maybe hold off. And then meds that are useful to make the heart beat faster when you want it to make beat faster. Atropine is the one that we learned in ACLS that is great for sinus bradycardia. I don't know, any seniors in the rooms, have you guys, any seniors in the room or chiefs, have you guys had any success with atropine? I always feel like that is like the sinking ship, and you take a bucket and you throw one thing of water over the side, and atropine has never worked. Anybody? Yeah, your patient's bradying down and dying, and you're like, push atropine, and they're like, it didn't do anything. You're like, great, okay, get the pads on. So, okay, what was going on? Okay. Yeah, I have not had any success with it. So it is in the algorithm. If someone is sinus brady and symptomatic, perhaps it is something to consider. Maybe I'm trying to think of the situation, maybe like a little old lady on the floor who's like, I'm feeling a little lightheaded, but I'm really okay. And maybe she's in complete heart block, and you're like, okay, well, I don't need to transcutaneously pace you. Maybe I'll give you some atropine before you go to the ICU. I don't know. If you have a really sick patient who's bradying down, don't count on it. Dopamine is a better bet to crank that heart rate up, as well as isoproterenol and epinephrine. Obviously, both things that you're going to be considering in an ICU scenario or on the way to the ICU. And then last slide, I think, is remember that if your patient is bradycardic, the ironic thing is that for the most part, patients who are at risk for experiencing sinus arrest, experiencing arrhythmia, are patients who have had ischemic coronary events in the past. So we love to give them beta blockers. So when those electrical systems finally do crap out, the fact that we have given them all these beta blockers never seems to help. So it can make for a sticky situation, especially right away. So if someone's on a ton of beta blockers, ton of calcium channel blockers, remember that if it's truly emergent, you can and should reverse them. It's just, I haven't done this, but you've got a patient with heart failure. They need a bunch of beta blocker to protect their heart. All of a sudden, because of their ischemic cardiomyopathy, they lose that electrical conduction system, and now their heart rate is really slow. This is a quick way to peel off your AV nodal blockers. So calcium chloride and calcium gluconate for a patient on high doses of calcium channel blockers, and then glucagon for your beta blockers, and then digibind for a patient who is experiencing bradycardia from digoxin toxicity. This is a nice set of guidelines from Jack on how to manage bradycardia. And that is it. I know that was a lot. It's fun to resolve arrhythmias. It's important to know how to manage them, because you just can't look it up when you need to know. So any questions? Yes, David.
For the tachyarrhythmias that you're going to treat with a beta blocker or calcium channel blocker, how much do you take the patient's blood pressure into account?
Oh, that's a great question. Super common issue with AFib with RVR. In my experience, and I'm happy to have anybody else weigh in, for the most part, if they're in AFib with RVR and they are in the high 90s, slowing down that heart rate with either metoprolol or DILT will improve those blood pressures. I've seen it happen a bunch where their systolics are in the high 90s and you're like, oh, do I want to do the DILT drip? Do I want to push the metoprolol? And you do it and their blood pressure is the next one's 110. High 80s, low 90s is a lot trickier. I don't know, other seniors, other chiefs. In some cases, especially if they're in ICU, I would do it. If they are not in the ICU and they're on the way to the ICU, maybe think about an amiodarone. I don't know, any other thresholds that you guys have? Or sorry, Ben, just hold on one second. Chiefs, seniors. Yeah. Yeah. And in general, patients are, if they don't respond to the initial dose of beta blocker, you don't have to try 3 more doses of beta blocker. You should switch to a calcium channel blocker and vice versa. Some people are just going to respond to one and not the other.
But then you just have to get it down to pharmacy.
Yeah. Yeah. Yep. Oh, sorry.
They're also on Tele and they are hemodynamically stable before, and then they go into the arrhythmia and they get hypotensive. It's much more likely that the fast heart rate is up in the hypo. And then you might feel a little bit more comfortable getting it. So it's really just relative.
Yeah. Ben. Some of the older cardiologists who I was on service with will digload people. It's certainly fallen out of favor. I've never given dig acutely for AFib with RVR or another like SVT or tachyarrhythmia. For the most part, the rate control is going to be from calcium channel blockers and beta blockers. And then maybe once you stabilize them, you could digload them overnight to try to get some of those calcium channel blockers, beta blockers off like the next morning. It's pretty old school. Don't see it done a lot.
Not as a result of like the beta blockers, but if someone was had a AFib with RVR with hypotensive, just as like a temporizing measure that
I don't think a digload works fast enough.
it's like last stitch. You tried everything else and they're still.
Yeah, it takes a couple hours.
You also won't let you do it like before you move them. I'm like, what if we get it down?
It's a rough.
Well, no, because it was
Yeah. That is unfortunate that happened. That is not always true. All right. Thanks, everybody. Oh, a couple questions. I'll answer them. Okay. Go to yeah, I mean, great question. So I guess I don't know if I'll answer the first question. What's the go-to for AFib with RVR that presents with CHF? If you suspect that the rate is driving the congestive heart failure, treatment of the rate takes priority. So feel free to use the beta blockers and calcium channel blockers to control the rate. Obviously, the calcium channel blocker contraindication in heart failure exists. I think in common practice, more people are likely to accept the risks of a DILT drip in someone with heart failure and AFib with RVR. In my limited experience, I have seen that work very well. So obviously you need to watch for cardiac decompensation in that situation, but I think in general, the beta blockers and calcium channel blockers are safe. What about patients with septic shock on norepi, also bradycardic to like 50s or even 40s? If you think that bradycardia is driving the hypotension, I think there could be a role for pacing. Septic shock on one hand is relatively well known for causing hypotension, so you may have a hard time convincing cardiology to do pacing like that, but certainly being on norepi should make you tachycardic. So the fact that they're bradycardic to the 50s on norepi, I think would be worth the consult. That would be my non-cardiology fellow chief resident advice. It's worth talking about with cardiology because a heart rate of 50 on norepi is not normal. Isoproterenol, if you can get it fast enough, epi usually around, and I think pharmacists can make push dose epi. Yep, that agree with that. I agree with that. All right.